Hello, I'm Smet, clinical nurse specialist of wound care in Ghent University Hospital in Belgium, and I will tell you a bit more about the inter and multidisciplinary collaboration in pressure ulcer risk assessment procedures and how we implemented it in a local setting, in this case, Ghent University Hospital. First of all, of course, it's important to have an idea what kind of institution is Ghent University Hospital. So we're the second biggest university hospital in Belgium. So we see 3,000 patients a day, more or less. There are more than 6,000 employees, and we have more than 1,000 beds. So it's a university hospital, which means that we also focus on scientific research. We have quite good collaboration with the faculties of medicine and health sciences and also the University Center of Nursery and Midwifery. And since 2006, we have also in the hospital a quite strongly developed wound care center. And this wound care center also cooperates with university via the Skin Integrity Research Group. So we have quite some connections, of course. First of all, it's good to know how the pressure ulcer management was organized before 2013 because we already had a pressure ulcer committee since 1987, but it was under the hands, or it was coordinated by the infection control department. We also saw that in other hospitals. An important for this factor or of this situation was that it was an additional assignment. So not the main focus, of course, but they had to also take care of the pressure ulcer procedures in the hospital. So what did they do mostly? They organized 3 yearly meetings of a pressure ulcer committee. And in that pressure ulcer committee, we had the purchasing department, of course, to buy and rent prevention of preventative materials. The nursing management was present. We had also from the university a representative, a dermatologist was there, 2 head nurses, and since 2010 also the wound care coordinator, which was me then. What did they also do? They were developing and updating the local pressure ulcer prevention guidelines. So there was a protocol. They also were responsible for the organization of the education of new employees, and also a yearly prevalence measurement had to be organized. But important, this was not hospital-wide yet. It was more a bit voluntary for wards that were able to conduct this prevalence measurement. After 2013, the coordination switched to the wound care team. What does it mean? This meant that myself was under control of the committee. And why was that switch made? Because hospital management wanted to have a bigger focus on the aspect of pressure ulcer prevention. The prevalence rates had to decrease, and this had to be done by a new pressure ulcer protocol in the hospital, a better execution of this protocol, and also a good education of already the healthcare workers that are already present, and of course the new employees. So a more continuous education instead of now a focus on the new employees. It's always important to know, of course, is there a problem? And we saw that the prevalence rates at that moment were fluctuating around 8%, which is not that bad, but of course is also not fantastic. What was more worrying was the amount of adequate prevention that was given to the patients. We saw in the measurements that were done that only 14% of the patients received adequate prevention while seating or lying in bed. And if we focus only on lying or seating, we saw that the adequate preventative measures were under 50% also. So there were indeed some things that had to be changed. So as I said, I took up the chair of the pressure ulcer committee, and the first step was to make this committee more multidisciplinary with, on one hand, relevant, but very important also motivated stakeholders, because you can have quite some maybe relevant stakeholders there, but if they're not motivated to participate, it will not help you much further. So which were the essential partners? You can see it here. So quite some head nurses, ICU, operation theater, rehabilitation had to be represented within the committee, but also still of the management, a representative had to be present because, yeah, you always need somebody from the higher regions who supports the decisions that are made. Also, the representative of the purchase department still had to be there, but also important, not only the purchasing of materials, but also the distribution, the logistics is very important. So it was a representative that was also in charge of that was there. And then also a representative of the plastic surgery department, because of course pressure ulcer management is strongly related also with the plastic surgery department. So we wanted them for sure also within the team. Some additional partners, more ad hoc, that should be there, focusing really on a plastic surgeon. And if we're looking really on procedures regarding pressure ulcer treatment, surgical treatment, we need a plastic surgeon. If it's more focusing on conservative treatment, we have the wound care team, but also has to be an involvement of a dermatologist is very valuable there. And also a partner who is responsible for manipulation and repositioning of the patients, because we can, of course, use the correct materials, but we also need to support our staff in how to manipulate the patient, how to reposition the patient on these materials. So also from that team, somebody was present in the committee on ad hoc basis. And the infection control department also, who was before the key focus or the key organizer of the committee, they were also there more in a more partial way. When necessarily, when there were subjects that are necessary, they were involved within the team. So you see a quite different approach that we had from then on. The next step, of course, is an identification of the obstacles and the needs on the wards. How did we do that? Was specifically questioning the nurses on the wards, working with the patients. And we did that during trainings, but also during the consultations of the wound care team. So the different nurses within the wound care team, when they were with patients, also for other indications, we checked the materials, we checked how everything was going, what needed to be changed, and so on. Of course, the members in the pressure ulcer committee also listened within their teams what was the feedback that we could work with. And not to forget, also the patients. We have to question also the patients regarding the preventative measures that are taking, maybe patients that develop a pressure ulcer, how they experienced this situation. So we came to some main results, and as you can see, the most important was that the current risk assessment procedure was too complicated. The reporting of Braden combined and also with clinical judgment combined with skin inspection didn't work. The administrative workload was too high. So also a quite strong perception that, oh, we're doing quite good in the hospital, so why do we need to change things? And then linked to that, a lack of insight in the prevention strategies and also the biomechanical principles. Why do we use these measures, and how do they help preventing us in the development of pressure ulcers? So quite some topics that popped up. And the next step was then, of course, checking the literature, which were at that moment the available and most recent guidelines. And then, of course, we knew that every patient should be assessed daily, or at least daily, and repeated as often as required. Assessment tools can be used, but you have to combine it with skin assessments and clinical judgment, and a prevention plan for every patient at risk. But at this moment, they already found the administrative burden high, the staff, and we didn't do systematically daily screenings of the patient. So quite a problem. So we saw for sure that, first of all, the knowledge of pressure ulcer management had to increase, because if they don't know the principles, it's also very hard to implement changes. So we started with education campaign, Also, we saw there that occupational therapists should be involved in the team, which was not yet the case, as they also very strongly involved, specifically also in the seating of patients. And we started also with nurse champions on each ward who can also fulfill the principle of train the trainer and who will be responsible for the quality measurements so that every ward have to participate and not ad hoc participate anymore. So what happens? We could evolve to a daily risk assessment and a more accurate prevention protocol, which was done on an individual basis. So we made it much more simplified, our risk assessment, but more feasible. And of course, the other partners now that we needed was our IT department and quality improvement department or quality department. Because how can we facilitate as much as possible that the risk assessment is filled in the system in a very easy way, but also how can we extract the useful data for our end users in a positive and a negative way. So to show them they're doing good, but also show them the points that we need to work on. Because that's also very important to motivate your staff. So as you can see until now, already a lot of stakeholders had to be involved to implement a correct and new strategy. And then, of course, once you start implementing, this is in some way additional that I just want to pass through to you, is always when you start the implementation, follow sort of flow chart and also take into account the needs before you start implementing, which recommendations are there. And I always like this publication of Powell, where you have very clearly some steps and strategies that you should follow. So you could have a look at it and I always check, did I follow all the strategies before implementing this change? This can really help you. So, and here you see quite some useful information regarding this. So anyhow, we could implement our new risk assessment protocol. Very nice was that we saw that the daily risk assessment was initially less than 50% of all our patients, and now we have figures of over 95% of our patients that get daily screened on pressure ulcer risk. Other hospitals in Belgium also started working with the same risk assessment. Now we're improving this risk assessment together with the other hospitals in Belgium, and we're striving to a uniform national risk assessment and in a second phase also prevention protocol. So we also could, you also can find a bit more information in a discussion paper we published in 2019. So of course, after now everything is implemented, you need to follow up, keep updating and implementing also new innovation. So in collaboration with the stakeholders. So at the moment, 4 times a year, we come together still with the pressure ulcer committee and we keep on improving. A next step was then a folder, not only for the patients, but also for the carers of the patients and also all clinicians in the home care setting to give them also the information how to do a correct risk assessment and how to fulfill on the correct preventative measures. So there again was a strong link with the rehabilitation center because they already had a patient folder developed, but specifically for their patient group. And also quite recently, we start with an additional 2-weekly multidisciplinary meeting, but specifically to discuss the challenging patient cases, and that are mostly patients then with challenging pressure ulcer wounds. And for there, we need intensive collaboration with the plastic surgery team, but also microbiologists, dermatologists, the wound care team, the social services, because it's very strongly linked with the situation at home before and after surgery, for example. And then also, of course, the rehabilitation team, as we see many pressure ulcers with patients that are para or tetraplegic. So as you can see also here, the collaboration multidisciplinary is very intense or need to be very intense. So for pressure ulcer management and more specifically also risk assessment, it's super important that you work together to be able to assess the risk, but also, of course, to develop a feasible protocol within your local setting. So I can only recommend to think thoroughly about the decisions that you make and to always consider to collaborate before implementing new strategies or to develop a local procedure regarding risk assessment.